Okay, then we have the last speaker of this first session, Dr. Xavier de Béthune. And Dr. Xavier de Béthune is health director with Doctors of the World in Belgium. And he supervised for 4 years an increasing number of programs taking care of the health and even more of the rights of migrants in Belgium. Please.
Thank you very much. Actually, I'm altogether very grateful to be here and to be able to present our work to you. And at the same time, I'm very humble because I'm going to try and let migrant people speak to you. And I'm not a migrant, as you can see. I'm one of the privileged people of this planet. And I think it's really important that in all these settings, in all the opportunities we have, we should put the migrant in front of ourselves and try and look through his eyes, listen through his ears, and see what it becomes, what it means to become a migrant, to make the choice of leaving everything you know, to jump into the unknown and to face the rough world of migration. So what we did is a small survey in the projects that we are running in 3 countries, Tunisia, Morocco and Niger, and we interviewed migrants on what it was to be a migrant and how it impacted their health. And that is what I'm going to try to propose to you, to present to you. The next reason I have to be very humble is because I'm in the Palace of Academies, and this is not an academic study. It doesn't fit at all with anything I know about scientific work. This is really operational work. We met with the people we could meet. We used a questionnaire that was not validated scientifically. Still, the information that is there is very, very useful, and I think it should be heard, and that's why I accepted to come here. I didn't do this study myself. My colleague, Estelle Spool, who has been doing the study, is presenting the results at the Marseille European Public Health Conference today. So she has no talent for ubiquity and she cannot be here today. I've put some citations across among the graphs and the numbers that we collected. And I put this one first because I think it's very important for you to know that we always see pictures of boats, and we have seen already one this morning, of boats loaded with people sinking in the Mediterranean Sea. What we do not see is the corpses lying in the Sahara. There are probably many more lying there. And if we have had the success of the European policy to reduce influxes of migrants into the European Union, we must know that one of the prices we have to pay is lying dead in the Sahara. So we wanted to make objective what it means to people to leave their homes and to go on a trip. And we were able to determine a few things about the general health status of migrants in our projects, the people we meet in our projects, not the general migrant population. And we tried to develop an adaptation of the access to care model, of the social determinants of health model to the migrant population that we saw in these projects. This is one of the examples of migrations. This is what happens in Tunisia. Women in Ivory Coast are loaded on a plane, arrive in Tunisia, are put in contact with a family, with a house where there will be a house worker, and the first thing that happens to them is that the family where they live will take away their passport, so that they cannot go elsewhere. This is a regular situation. We don't see this. Tunisia is a country of destination. We don't see this in Europe. But Tunisia, for many people, is a country of destination. And the migration situation there is not good for most of the people who reach that country. So, just a few words on methodology. We, as I said, we did the survey in 3 countries, but in 4 locations. In Morocco, we had 2 locations in Rabat and in Oujda, with different situations. In Rabat, for instance, we have a program that was supported by the EU and that tried to restore the rights of access to sexual and reproductive health to migrant women, meaning we have only a woman sample in Morocco, in Rabat, so which biases our data, of course. We interviewed 468 migrants and then discovered that there were kids between 0 and 3 in our database, so we had to skip 7 of those questionnaires, which is not too bad for a survey. And we conducted a number of focus groups as well in the countries where we did our survey. So as I said, we have 60% of women, but that's due to the kind of projects that we run. So it's not a representative sample of the migrant population. What is representative is the age of the migrants that we saw. The median age is 28 years, and which confirms most studies and which is coherent with what we see, that people who migrate are younger than the general population. And of course, given the location of our projects, almost all the people we saw came from sub-Saharan Africa. Therefore, going on a migration trip is a long project. People are more than half of the people, about half of the people are there for more than 6 months, are traveling for more than 6 months, and 47% of the people stayed in the country of interview for more than 12 months. Even if their plan was to go further, they were stuck there. And if we look at what happens to them, the first thing we tried to investigate through our survey was, have you been subjected to violence? And the citations are like, I've been subjected to an enormous number of psychological and physical acts of violence. And that's not that's a sample, but that's a very regular statement in the interviews we took. And the violence doesn't start on the route. It starts in the country of origin. If we look at it, the journey, of course, is a risk in itself. We see that people, when they migrate, I suppose this is when people migrate, we see that they have about 61% of the people who experience violence. But if we ask over all their life, we see that the violence starts in the country of origin. Only 16% of the people we interviewed said that they had not been confronted with violence. Only 16%. It's violence of all kinds. It's maybe financial violence. If you want to rent a room in Morocco, the rent will be higher if you're a migrant than if you're a Moroccan. But also it could be institutional violence. People wearing uniforms are a real threat to migrants. If we look at the differences between the sexes, between the genders, you have here the men and here the women, and there are a huge number of kinds of violences where the people can be subjected to. If we start with the most cruel one, the sexual violence, we can see that rape is here on top of the chart. Of course, it's more for women than men, but we also see that sexual violence, which is here, is also a big cause of violence. And if we take the most unacceptable one, in my eyes, the institutional violence, the confiscation of money, of documents, the being put in prison without no reason other than being a migrant, or pure, simple physical violence by officials, and then we see that it's here at the bottom, and it's a huge chunk, and of course women are more subjected than men. Prison is more frequent with men than with women, but it's the number of types of violence that these people have to confront with, are confronted with, is enormous. Borders. You know that I'm working for Doctors of the World, but you all know Doctors Without Borders. It's not a chance that they chose this name. Borders are a huge risk factor. Crossing a border is a danger. Even if you have all the necessary documents and you're on a migration route, crossing a border between two countries where you are allowed by any means to be, it is always a risk. And of course, sexual violence, as I already said, is a very big issue. If you look at differences between locations, you see that the country of origin, this is of course a percentage chart, but if from the moment you get on the road, the violence increases in the terms of institutional violence. It's also true that staying somewhere seems to increase the risk of psychological violence. So there's not one kind of violence that could be explaining the whole set of problems these people face. They are confronted with different kinds of violences at different moments of the route, but violence is never far away. We only recorded 2 types of violence for each migrant. So if we had recorded everything, the graphs would still look different. Healthcare is another issue. Not having access to healthcare is a major burden on these people. Some wait until they get better because they anyway don't have the means of going to a healthcare system. The other one is, as has already been mentioned by former speakers, the cultural differences and of course the discrimination that goes with it. Language is an issue that can be overcome. Culture is a much tougher issue, and of course pure blank discrimination is very prevalent. If we look at it, 60% of the people we interviewed told us that they had had problem to access healthcare. Of course, some of the others didn't need healthcare and so didn't report having problems with that. If we look at what are the main causes, half of the barriers are linked to resources, no money, administrative documents lacking, transportation means not present, and the other half comes from social barriers, the environment where those people live in, the discrimination or the cultural. It was mentioned before that not knowing how the health system works is a major issue, and of course we are there as Doctors of the World not to treat these people instead of the local health services, but to do everything that we can to get them inside the health service. We're working together with them so that they can get there, and we're working together with the health services so that they would accept them, and so that they would take care of them in a proper and in a human way. Health status has been mentioned several times. Health status is good when they start. It very rapidly degrades. We are still in Africa here, and half of these people say, my health status is not what it should be. And this is enormous for a young population. I repeat, the median age is about 30. It's half of these people say my health is not good or is not satisfactory. And that is something we can collect quite easily. We have tools to measure quality of life and quality of health status, and these things can be collected quite easily. We don't need huge databases to know. People report what they feel. The main form of suffering is not bacteria or wounds or physical disease. The main source of ill health is, of course, psychological. These people don't know what their future is going to look like. They don't know what their future is going to look like tomorrow. They don't know what their future is going to look like down the road. Every border crossing creates a new kind of uncertainty. They cannot make a plan for their own life, but they also are subjected to the insecurity they are living in, and the next time they will be cheated upon by other people. So some of them stay in the end. They do have the route, and then they stay where they are because they cannot cope anymore with the difficulty of having no future. It's not a one picture. It's not one graph that can represent all this. There are very many differences. I think you already noticed this in my speech. There are different routes of migration. I told you about the women in Tunisia. They are put on a plane. They have a right to enter in Tunisia, so nobody stops them at the airport, and then the problem begins. In other cases, you go on foot, take a bus, cross a first border, cross a second border, and then suddenly you need to cross a border where you don't have any legal document anymore, and then you will get into trouble. So there is no one migration route, certainly not. It's also different states. People stay for a longer period in some places and just go through in others. In Agadez, when I was visiting there, the mean duration of stay was 7 days. In Rabat or in Tunisia, people can stay for years before they find a way to escape on a floating device. Let's not call it a boat. And of course, it's differences in the epidemiology of violence. It's more violent towards men than towards women, but if you look at specific forms of violence, of course, women are more subjected. So, very shortly, a few recommendations that we could get out of our study. First, human rights are human rights. Migrants are humans, so they should have human rights. I think it's as simple as that, but it's not implemented in that way. Access to basic services, including, of course, health services, should be the basic of what we try to do there. It's not at this moment. We need to build up the capacity of health systems to meet migrants. We need to create interpretation services that are sure, that are reliable inside the health services, so that this language barrier cannot be a problem. We should be much more attentive to mental health care. We have no good solution for that. It's quite costly, but we should be doing that. And of course, people in the health services of a destination or of a transit country should be aware of the epidemiology of the country of origin to take care of those people in the regular way. There's lots of efforts building support from the community. If I look at Belgium now, the Plateforme Citoyenne here in Brussels is a spontaneous movement that has needed to be structured in the end, but there is community support. That community support exists as well in the countries of transit. It exists in Niger. Very poor people help migrant people in the ghettos. In Tunisia, there has been a surge of help for Syrian and Libyan refugees in Tunis. So it's there. We need to support that, we need to reinforce that. We have launched an initiative which is called Ending Violence Against Migrants that looks at all those determinants. You have the website on the slide. And of course we should do much more research. And as a small contribution to research, we have tried to extract from our data social determinants model of what impacts the health of migrants. It's a rough attempt. It's certainly not complete. It's based on the data that we have collected and a small literature review. If you want more of that, I've put some copies of the report on the desk at the entrance. You can take a copy there. There are copies in French and in English. But of course, it's based on the general social determinants of health model, meaning that. Oops, sorry. Meaning that you have those socio-economic and political determinants as governance, macroeconomic policies, and social policies, and that lead to indirect intermediate determinants of health as the epidemiology of the geographic area, but also of the country of origin, the phenomenon of exile itself, the fact to be alone, to not be able to trust, to be in a situation of insecurity. Of course, the living conditions are terrible, and we should add here, I learned that this morning, access to work. On the living conditions, it's not there because we didn't ask for that in our survey. Thank you very much. And of course, access to healthcare. And those intermediate determinants should be studied and are a program for research because we don't know enough about it. And the rest is quite classical. It's what we know about the social determinants of health. This is the web link to the report, but I just wanted to. We talked with the person who is going to animate the debate later before on the phone, and she told me, "What about Belgium? You're only speaking about Africa." So I rapidly added a few slides of Belgium, because in Belgium we did something very original, I think. We discussed. We were asked by the Committee P of the police, according to some lobbying and some cases we published in the press about violence against migrants here in Belgium, and especially against trans migrants. The Committee P of the police came to us and told us, "Could you make this objective, please? We don't want this. We want to make this. We want to correct the situation." And so we interviewed trans migrants, and it took an enormous amount of effort to do this in a non-intrusive and a non-traumatic way. We interviewed 440 trans migrants, of which 25% reported to have been subjected to violence in Belgium. It was quite a discovery. 51 realized an in-depth interview about what happened during those episodes, and of those 51 people, there were 101 acts of violence that we could report. Physical violence, psychological violence. It's puzzling for a country as Belgium. And we published a number of recommendations according to this study. I'm going very fast. I agree, but we thought again. Human rights and legislation for arrested migrants should be respected. There should be no deprivation or physical violence. Some of these people are put in cells without water, without food for 24 hours. We asked that no psychological or racist violence should be present, of course, and no bereavement. A cell phone is a lifeline for a trans migrant. If you take it from him, he's very likely to be subject to more violence whenever he's back on the street after that. We are going to implement the first training session with policemen to try and create decent, human, respectful relationships with trans migrants. And there have been a few meetings already with the police to talk about the problems and how they could cope with it. So, operational research, I would say, and a few signs of hope there. I have a few copies of the report we did, but I only have it in French. I have it with me. Thank you for your attention.